Welcome, my name is Victoria, and in today's study session in preparation for Nclex, we will be talking about esophageal varices. Esophageal varices are dilated and tortuous veins that are located in the submucosa of the esophagus. This tortuous vein is caused by portal hypertension, often associated with liver cirrhosis, where we have fibrotic liver disease that causes a build-up in pressure in the liver, causing portal hypertension, which is characterized by increase in the blood pressure within the portal vein by 10 millimeters of mercury. Now, these veins, they are at high risk for rupture if portal circulation pressure increases. Varices are life-threatening emergencies that require urgent management for this case. So we have said that the esophageal varices are enlarged, fragile, and overdistended veins that are located also in the distal parts of the esophagus, and then it happens due to congestion, venous congestion in the portal vein. For the clinical manifestation, the patient will have hematemesis, which happens due to ruptured varice. And then we are going to see a change in the vital signs. The patient will have tachycardia, hypotension. Also, if bleeding is slow, that is the one we call the oozing varices, then we'll have this tachycardia and hypotension. Then we have melena, that is the blood in stool, where the varice ruptures, and then the blood gets digested and is passed out in stool. The bleeding can lead to ascites. And then remember that this esophageal varice is a complication of liver cirrhosis. So we can also see these patients having jaundice, hepatomegaly, and splenomegaly because the portal vein is having hypertension. There will be shunting of blood. The blood will try to be diverted to other parts, other areas. So it can divert it to the splenic vein, to the mesenteric vein. And as it's diverting that blood, we'll have enlargement in those areas. That's why we have the splenomegaly, the hepatomegaly, as well as dilated abdominal veins because of the shunting of blood. We've already talked about the signs of shock that accompany this whole thing. Therapeutic management includes stopping bleeding, either by using sclerotherapy, where there is an injection of a sclerosing drug. Another thing that can be done is banding of this outpouching of this varice. They can use like a rubber band. It has to do with the use of a rubber band to occlude the bleeding vessel. They call it band ligation. So a rubber band is just used to kind of tie the varice and prevent it from rupturing. Esophageal tamponade can be done too. This one involves the use of direct pressure. We are going to be using Sengstaken blakemore, that blakemore tube, or the minnesotatube with esophageal and gastric balloons. We are going to be using it to serve as a tamponade. Let me talk more on this Sengstaken blakemore tube. Let's revise it more. So this tube is used only occasionally, and then it has 3 lumen. It's a triple lumen gastric tube with an inflatable esophageal balloon that will compress the esophageal varice. It also has an inflatable gastric balloon. That one too applies pressure at the cardioesophageal junction. And then we have a gastric aspiration lumen. That's the 3rd lumen. So a nasogastric tube also inserted in the opposite nares. That's the opposite part of the nostril. If you put it on the left side of the nose, another NG tube can be passed in the opposite side of the nose to collect secretions that accumulate above the esophageal balloon, because we are trying to create a tamponade and then stop the bleeding. So whatever blood has collected above that inflatable esophageal balloon will be suctioned out gently. It will be withdrawn, it will be removed through the NG tube in the opposite nose. More commonly used is the minnesotatube, which is like a modified Sengstaken blakemore tube. Now, it has an additional lumen. So, the minnesotatube is a 4-lumen gastric tube. And that 4th lumen is the lumen that we'll use to aspirate the esopharyngeal secretions. After passing the tube, placement is confirmed by a radiograph of the upper abdomen and chest. Our nursing intervention include: you need to check for patency and integrity of all balloons before insertion. So as you are taking the blakemore tube, NG tube, you are looking, is the balloon part leaking? Is it patent? Is it all right? Then you have to label each lumen. Okay, this one is for the esophagus. This one is for the gastric area. You need to specifically label it so that you don't confuse. When you want to deflate the tube, you don't confuse them. That is an important Nclex tip there. Place the client in upright or Fowler's position before insertion. Then immediately after insertion, we prepare the client for radiography to verify placement. We are to maintain head of bed elevation once the tube is in place. Another Nclex tip here says that double clamp the balloon ports to prevent air leak. So we don't want, the balloon will be inflated so that it stays in place and has this tamponade effect which we want. That is why we are inflating the balloon. So the gastric part, that is the one that is placed at the cardio-esophageal junction, the inflatable gastric balloon will be, the air will be pumped into it to inflate it and give this tamponade effect. Then the other part too, the esophageal part, will be inflated. So we are to make sure that we double clamp, use 2 clamps to close that balloon port to prevent air leaks. Next point is scissors. You need to keep scissors at the bedside at all times. Yes, because in case of an emergency and you need to resuscitate these patients, you just cut it off. You need the scissors. The scissors is needed to cut off and deflate the balloons so that we can take out the NG tube and then do our cardiopulmonary resuscitation. To prevent ulceration or necrosis of the esophagus, we need to release the esophageal pressure at intervals, and these intervals will be prescribed by the HCP. Also, we monitor for increased bloody drainage, which may indicate persistent bleeding and rupture of the varice. Monitor for signs of esophageal rupture, which includes a drop in blood pressure, increased heart rate, back and upper abdominal pain. Let's review the nursing management in another material because I read from different textbooks. So this other material is saying to maintain airway, breathing and circulation while on the blakemore tube, monitor vital signs and initiate cardiac monitoring. We know we have to initiate cardiac monitoring because these patients, they are hypovolemic, they may be losing blood. This process is associated with ascites, so there will be dysrhythmias. That is why we need to monitor for the cardiac. We need to do cardiac monitoring. Also, said to start 2 large bore IV with infusion of normal saline, because normal saline will help to increase the intravascular volume and increase the blood and maintain intravascular volume, so that as they are losing blood, or if in case it ruptures and the patient starts bleeding, we are not going to have volume depletion and the patient can now enter hypovolemic shock. For the lab test, he said we should do complete blood count, we should do grouping and cross-matching to check the blood type. In case this varice ruptures, the clients will need to have blood transfused to them so that they can have hemostasis. That's why that point is raised. There's another point that says that begin gastric lavage if prescribed. All right, if prescribed. Okay. Then said keep the client MPO for both sclerotherapy and esophageal tamponade if elective. So this one is talking about a situation whereby a client came to the clinic and then they have been diagnosed of this esophageal varice, and then you schedule them to come in for either sclerotherapy or this esophageal tamponade. So if we schedule them, we can now say, okay, when you're coming in 3 days time, come fasting, don't eat any food, don't take any drink, and just come MPO like that. Also, we can administer propranolol as prescribed. Propranolol is a beta blocker that reduces portal blood pressure. Another medication that can be given is sandostatin, SANDOSTATIN. It decreases the splanchnic blood flow to decrease bleeding. So blood flow to the vessels in the abdominal region, that blood is being shunted to from the portal venous system. The blood pressure there too can be reduced gradually so that there'll be low risk for rupture. Let's talk about something. Let's talk about the contraindications to use of this Sengstaken blakemore tube. Patients that have history of esophageal surgery or already existing ulceration or necrosis of this esophagus cannot use the blakemore tube. So we have said that we use it as a kind of tamponade for varices in the esophagus. But if this patient has a history of surgery, they've done maybe one kind of surgical repair affecting the esophagus before, they cannot use this tube. And a quick review on the Sengstaken blakemore tube from another material. So it said it has 3 lumen, 1 gastric lumen, which provides low intermittent gastric suction, and then a tubular esophageal balloon that applies pressure against the bleeding vessels. They said the gastric balloon is inflated first. So we inflate the balloon going to the stomach first, and then the esophageal balloon is inflated next. 25 to 45 millimeters pressure, that is what we use. So if a question comes in Nclex and we say what's the pressure, or which of the following is the pressure used in blakemore tube, you now see 10 millimeters of mercury, you see 80 millimeters of mercury. Those ones are not correct. The correct answer is 25 to 45 millimeters of mercury. That's the pressure. They said traction on the tube is needed to maintain position of inflated balloon. So the blakemore tube has an inflatable cuff that is going to anchor it at the nose region. So that inflatable cuff will be, I think that's what is used to give traction to the tube to help maintain the position in the esophagus. Check placement of tube by X-ray of the chest and upper abdomen. So specifically is the X-ray of chest and upper abdominal region. Please forgive me. Just excuse me. Prepare to insert NG tube in the opposite nares for suction. So we've already talked about that. And then they also said that the minnesotatube is similar to the Sengstaken blakemore tube, but has additional, that's the fourth lumen we talked about, to drain secretions from the esophageal area, eliminating the need for a separate NG tube placement that is used in the Sengstaken blakemore tube. Let's also remember that this balloon tamponade is not frequently used. We said that earlier in this study session, that it's not frequently used because it can be very uncomfortable for the client, and its use is associated with complications. We are to prepare to assist with the administration of medication to induce vasoconstriction. So any medication that we know, like vasopressin now, they can be prescribed. And that vasopressin, if it's prescribed for this patient that have esophageal varices, it can be given IV infusion, continuous or PRN as prescribed. So let's take notes. Also, we instruct the clients to avoid activities that will precipitate or that will initiate the vasovagal response. For the endoscopic injection, that's sclerotherapy, the procedure involves injection of the sclerosing agent into and around the bleeding varice. Complications associated with sclerotherapy include chest pain, pleural effusion, aspiration pneumonia, esophageal stricture, and perforation of the esophagus. So these are the complications we see in sclerotherapy. The patient can start to have chest pain. There may be pleural effusion if it gets into the lung space. Patient can also aspirate during this procedure, causing aspiration pneumonia. Then if the sclerotherapy becomes too effective, it can result in esophageal stricture and perforation of the esophagus. For the band ligation, it's also called endoscopic variceal ligation. This procedure involves ligation of the varice with an elastic rubber band. They said sloughing followed by superficial ulceration will occur in the area that was ligated within 3 to 7 days. So that's how this endoscopic variceal ligation procedure occurs. So it's done through an endoscopic technique where they go in there and use a rubber band to tie the varice. Before you know it, it will start. There'll be ulceration at that point, then sloughing, and that will cause ligation of that area within 3 to 7 days. So you can seal it up, and that outpouching will stop. Another procedure that can be done for esophageal varice is the shunting procedures, where blood is shunt away from the esophageal varice. They are trying to divert the blood away from that varice so it won't accumulate there. Portal-caval shunt involves anastomosis of the portal vein to the inferior vena cava, diverting blood from the portal system to the systemic circulation, because we know that this varice is caused by portal hypertension. Another procedure is distal splenorectal shunt. Like the name implies, splenorectal. So we know that this shunt has to do with an anastomosis of a splenic vein to the left renal vein. So the splenic vein is joined to the left renal vein rather. The spleen will now conduct blood from the high pressure varice to the low pressure renal vein. So it will divert the blood. We also have the mesocaval shunting, which has to do with an anastomosis of the superior mesenteric vein to the proximal end of the inferior vena cava. So we are shunting blood from the superior mesenteric vein in the abdominal region to the proximal end of the inferior vena cava, so that it can divert that blood from the esophagus to the inferior vena cava. Another thing that can be done is the procedure called the TIPS, which stands for transjugular intrahepatic portosystemic shunt. The procedure uses the normal vascular anatomy of the liver to create a shunt with the use of a metallic stent. The shunt is between the portal and systemic venous system in the liver. So they are shunting blood between the portal vein and the systemic venous system within the liver. And it is aimed at relieving the portal hypertension. It reduces portal hypertension by diverting blood flow around the liver. All the blood that is flowing around the liver is being diverted. I hope you found this study session helpful. Thanks for listening, and see you in the next one.